Hello, and welcome to a session of digital pathology instruction and tutoring on breast carcinomas. Our program is made possible by Path Presenter and the Digital Pathology Association, the Digital Anatomic Pathology Academy. But I'm also very grateful today for the assistance of my colleague and one of our excellent trainees, Dr. Tim Ramsayer. Who's helped to prepare and locate the cases and has also provided some of the annotations. To get best value out of this tutorial, I strongly recommend that you go to the link in the video and there in the comments section and study the digital slides yourself. They're available publicly without charge or anything like that for you to study, and that's really going to be the best way for you to master this. I'm going to go through this fairly quickly. I'll hit some of the high points. We'll touch on some of the differentiation issues. But I think really what's going to help you the most is coming back and studying the images yourself on your own device so that you can see what it is. So this is the most recent WHO classification of epithelial breast cancers, which is our topic today. Obviously, we'll spend most of our time on the more common lesions, the no special type, lobular carcinomas. We'll touch on some of these less frequently encountered ones, and we'll touch on some of the issues related to differentiation, grading, and those kinds of things that become important in classification. So I'm going to expand my screen here. And we'll go on to the topic, first of all, in situ carcinomas. These are divided into two types: ductal carcinomas, by definition, within the ducts, but more specifically arise from ductal epithelial cells. These generally tend to be larger cells, and they can produce a variety of patterns: a solid pattern, cribriform pattern, clinging type of pattern. There may be comedo type of patterns, high-grade nuclei with so-called comedo necrosis. Sometimes you'll also see calcification in that necrosis or in the intralumen. And with these tumors, our practice is to grade them based on nuclear grade and to report the specific type along with the morphologic features like necrosis and calcification, as those may impact both follow-up and to some degree decision as to treatment and so forth. Lobular carcinoma, by definition, would be within the lobules or derived from lobular epithelial cells. In general, there's a morphologic cutoff here that we would like to see more than 3 lobular spaces that are enlarged and completely filled by these small cells. When you have when you have 3 or less, generally, or they're not quite completely filled, there's maybe a small lumen left or something like that, you may use the term atypical lobular hyperplasia. Now, I mentioned that this is within the lobules, but of course, the lobules and the ducts are contiguous, and so spread into the terminal ducts and occasionally into the larger ducts can also be seen with this lesion. Immunohistochemistry can help us. These tend to be E-cadherin negative and P120 positive, which, if you have doubts, are 2 useful stains to employ. And in general, we tend to prefer having 1 negative and 1 positive to verify lineage so that we're not just relying on a false negative or potentially a false positive. In contrast, of course, ductal carcinomas will be E-cadherin positive. In addition, of course, there are overlap areas or gray zones with ductal carcinoma in situ with atypical ductal hyperplasia. Again, the criterion is the number of ducts that are affected and that generally the extent of the changes. So recognizing that that's a more difficult cutoff sometimes for many practitioners. So as we begin to look at these, we'll start with this case, which at low magnification, you can see has this nice sharply defined ductal structures here. And there's very little, if any, reaction in the surrounding fat. So that tells us pretty much right off the bat that this is probably confined to the ducts. It's not producing a mass lesion. It's not providing much of a response. We can also see that there's probably some calcification or necrosis associated with this by this dark purplish material here and the central hemorrhagic cellular detritus. Now, here is another feature that sometimes can be confusing in ductal carcinomas, and that is that just as lobular carcinomas can extend into the ducts, ductal carcinomas can extend into and displace lobular epithelial cells. Note, however, that here are these tightly clustered spaces, a pre-existing lobule, are not completely filled, they're not solid. So this helps you to distinguish again that this is not lobular carcinoma in situ. This is a ductal type carcinoma. And here's sort of the clinging pattern, if you will, of in situ carcinoma. Here an example of a more solid pattern of growth. Now in general, in situ ductal carcinoma tends to be fairly monomorphic in terms of nuclear size and shape, especially in the lower grade lesions, in contrast to atypical, or excuse me, to usual ductal hyperplasia, which can actually have a fair degree of pleomorphism. We'll just see what the other features are here. Sometimes you can get these sort of vacuolated spaces, as you see here, and then here the necrosis in the lumen with the calcifications that we saw earlier. So this would be probably graded as a sort of low to intermediate nuclear grade, solid and focally comedo types with necrosis, with calcification. Let's take another look at a contrasting case. Here we see, again, not much of an infiltrated pattern, but we do see a little sort of a busyness over here and some more solid areas here that raise concern for a neoplasm. Here's some normal ducts and lobules over here. So we'll come and look at this a little bit more closely, just in contrast to the case that we previously looked at. Here are lobular spaces that are, several of them are expanded. So they're meeting that criterion. They're expanded lobular spaces. They're completely solid. They're filled by these fairly small and quite uniform cells, which expand the structures and fill them completely. Now, it's not as bulging as perhaps some lobular carcinomas might be. And as we look a little further over here, I think we'll see that this is extending into some of these more typical terminal duct type structures here as well. So this certainly looks to be on the lobular carcinoma end of things. Again, the nuclei are not very pleomorphic, but one of the features that can help us to recognize lobular carcinoma is the presence of intracytoplasmic lumina. Notice these little small pale areas in many of these cells. These are what have been termed intracytoplasmic lumina, and occasionally they can become large enough that they actually form an indentation on the nucleus, producing a sort of signet ring type of impression in some of these cells. In some instances, that may be a very pronounced feature of the tumor, and it will actually look much like a signet ring carcinoma from other sites. However, it will not be positive with mucicarmine. The lumen is not filled with a mucin, but with other cellular fluids that do not stain with the mucicarmine stain. So there's two quick examples. Now we have other things going on here, and we're not going to touch on that at this point. but recognize that lobular carcinoma and ductal carcinoma can spread within these zones of contiguous architectural features. So what are the boundaries? Well, I put this case in to compare. Again, this looks like a kind of a busy structure. We have a more solid area here, and we have a few enlarged ductal spaces here, and one here that begins to look like sort of a cribriform carcinoma. Cribriform ductal carcinoma in situ is generally characterized by rounded, somewhat punched out spaces. The nuclei tend to orient towards that lumen rather than being sort of a streaming oriented towards the bridge form. These are sort of in between. There's a little bit of streaming, but there's also a little bit of orientation. And there's just a couple of ducts here that are showing this pattern. So if you just have a few ducts like this, then making the diagnosis of atypical ductal hyperplasia is appropriate. This is a more confluent, probably papillary type structure. It certainly looks to be fairly confined, but some intraluminal architecture with blood vessels and so forth. Again, with these sort of rounded mostly, but slightly irregular features of the cells that are oriented towards the lumen. So again, a little bit on the, I'm not quite sure if this is ductal carcinoma in situ or hyperplasia. I'm not quite sure. It could be, it's sort of atypical. And then over here, we have the pattern of sclerosing adenosis with lots of small ductal type spaces or little small spaces with variable cystic structures. And this is mixed with a somewhat fibrotic sclerotic background. This is a benign change, but sometimes these kinds of structures can be involved by a more confluent proliferation like this we're seeing here, which begins to look like ductal carcinoma in situ. Now, there are useful immunohistochemical features that can be used to differentiate usual ductal hyperplasia from ductal carcinoma in situ, and those include the pattern of estrogen receptor staining, which will be clonal, in other words, uniformly dark in ductal carcinoma in situ of the low-grade type, and the CK5-6 pattern, which will not stain any of the central luminal cells, but will only concentrate around the periphery of the lesion in the myoepithelial component. But if that's present in the midst of the lumen, then usually you're dealing with usual ductal hyperplasia, which was the case in this situation, but with some degree of atypia, not fully classifying as ductal carcinoma in situ. So we'll go on to the next case. Oh, the same slide. Well, you get to do it twice. This time, let's look at this other area down here, just for fun, and evaluating another area of the same slide. Are there features here that overlap? Well, this is, again, a little bit more of a confluent papillary structure and not something that I think particularly looks like ductal carcinoma in situ, except that you're getting these rounded spaces with spherical collagenosis in here in some of these situations. So don't mistake collagenous spherulosis with ductal carcinoma in situ either. Another example, again, sort of a complex epithelial lesion here and a little bit of epithelial proliferation. This not forming solid proliferation, but showing this sort of clinging pattern around this duct with a little bit of papillarity, a little bit of elongation here. Columnar cell change has been cytologically linked to ductal carcinoma in situ. And so some of this could be columnar cell change with a degree of atypia. Here you see some stratification, some nuclear atypia. And then here we're seeing a little bit more tufting and sort of more solidish type of things. But this is not very widespread. It's just in a few ducts. It's not a fully developed lesion. So using the term atypical ductal hyperplasia in a setting like this is appropriate because it's not fitting into one of the well-defined ductal carcinoma in situ patterns, but we do have this columnar cell change with atypia, and we do have a little bit of sort of atypical debris and some beginnings of more solid type of an appearance with this sort of early tufting or papillarity into the lesion, into the lumen. Okay, here's another example. This may be a little bit more subtle. We have some Apocrine metaplasia over here. And here we again have some sort of complicated ductal appearance, not solid growth, but a little bit of this sort of micropapillary appearance in a couple of these ducts that's associated with some degree of cytologic atypia. We get a little bit of inflammatory reaction here. And so while not meeting the criteria for either clinging or micropapillary or solid or comitocarcinoma, the atypia, the occasional papillary structures certainly raise concern that this could be a precursor lesion for a more serious carcinoma. So using the term atypical ductal hyperplasia is appropriate in this setting. And this is one way of communicating to the surgical colleague that this is a lesion that could be related to other changes elsewhere and therefore needs to be excised with a little bit more generous sampling than has been given to us on just this simple needle core sample. So we'll see here a slide from the nipple, and we'll sort of turn it upside down here. So we get the skin on the top. Nipple, smooth muscle, subareolar ducts with their characteristic dilated appearance. But I'm going to call your attention here to what's going on in one of these subareolar ducts here. Notice here that the epithelium looks a little bit busier or a little bit thicker. And as we come into higher magnification, we also see this little lobular structure here. Now these lobules are not expanded. They're filled. And so it's atypical lobular hyperplasia in this lobule, but it's not quite lobular carcinoma in situ because it doesn't really expand any of these lobular spaces. However, what we do see here in this duct is a diagnostic feature of lobular carcinoma in situ, and that is this quite extensive pagetoid spread and proliferation in the subsurface epithelial space. So if you can imagine here, what we're seeing is a very attenuated ductal lining cell along the surface here of this space. And then these very fried egg appearing type of cells with very uniform nuclei, moderate amount of cytoplasm, and some degree of atypia. And they are just taking over this space. They're just completely displacing and pushing upward the normal ductal lining cells. And they're the same cells that we're seeing here in this little lobular space. So in reality, this is not atypical lobular hyperplasia. In this setting, this is lobular carcinoma in situ. and it's lobular carcinoma in situ that is extending in pagetoid fashion into this subareolar duct. Now, seeing this, we should ask ourselves the question immediately, what's going on elsewhere? Is there invasive disease? Is there something else going on? Well, looking at this other lobule here, we see again this same sort of proliferation involving that lobule. And then we should look to see, do we have extension further into other of these subareolar ducts? And more particularly, is there a chance that we also have Paget's disease of the nipple? Because this is one of the precursor lesions that can extend to and involve the epidermal structures of the breast. So if we could come into focus here, I apologize for this. I thought my server would be more rapid in response today, but it's coming on okay. So if you are like me, you're picking up on something, even at this magnification, that doesn't belong here. You can see we've got a few cells with a few sort of punched out cleared areas around them along this dermal epidermal junction. So there's a very strong chance in this situation that some of these cells are going to be Paget's disease of the nipple that has extended up from the underlying pagetoid spreads in the related ducts. Now, you can do, of course, special stains. You would not want to use ECAD, of course, but cytokeratin 7 and P120, HER2 sometimes are all excellent stains to help demonstrate the possible presence of lobular carcinoma in situ that has extended to become Paget's disease of the nipple. Just some thought processes to be aware of when you see that sort of involvement of subareolar ducts. Now, this is a case of invasive lobular carcinoma, but shows a more classic appearance here in this focus right here of what we would like to see for lobular carcinoma in situ in terms of expansion of the lobular spaces. So here we see these lobular structures, sort of a clustered group, but they're quite distorted and expanded by this uniform population of the malignant neoplastic cells. Now, sometimes you can get a little bit of pleomorphism in lobular carcinoma. So sometimes the cells will be sort of in transition from this more small cell type to a more pleomorphic or larger cell type, and varying degrees of atypia can be encountered. Now here's actually an in situ lobular space, but then here we see the same cells that have destroyed the stroma and are beginning to invade into the tissues. So while we're on this slide, we'll look a little bit more at some of the features of invasive lobular carcinoma, which we will touch on again later. And these are evident at kind of intermediate power as this very fine sort of infiltrative single cell pattern that you see here. And I apologize if this slide has this terrible smudge mark. This is not one of our slides. It was scanned in by another person who didn't understand how to clean their slides before scanning. But this shows you the classic Indian file or single file appearance of lobular carcinoma with occasional clusters and so forth of these cells with this very uniform, but certainly atypical nuclear features. So when you see invasive, think of in situ. When you see in situ, certainly keep your eyes wide open for possible subtle patterns of invasion. All right, well, so the most frequently encountered type of carcinoma, previously termed ductal carcinoma, has now been sort of rephrased or retermed the no special type. But there are a variety of variants that can be seen with this. We're not going to spend much time, if any, really, on some of these areas, these variants, but be aware that they're out there. In your career, you'll encounter medullary carcinoma, probably a tumor or two that has osteoclast-like giant cells, occasional neuroendocrine differentiation, and these other less frequently encountered patterns as well. So we'll just sort of leave that for you to think about. In general, the no special type is composed of cohesive cords, clusters, and trabeculae of cells. Sometimes these will form sheets of cells. And occasionally there can be sort of single file infiltration, but generally we like to see these larger clusters and groupings. These do express E-cadherin, and in a fair percentage of the time you'll find in situ carcinoma of the ductal type. These tumors are graded using the criteria developed by the Nottingham group that is based on a 3-feature scoring for architecture, nuclear pleomorphism, and mitotic activity. So let's talk a little bit more about that. This amount of tubule formation is scored as 1, 2, or 3. If it has good tubule formation in the majority of the tumor, you can score it a 1. If it has occasional tubule formation, less than 50% of the tumor, you can score it a 2. If it has no tubule formation, like invasive lobular carcinoma has no tubules, you would score it a 3. And the mitotic score is determined by the number of mitotic figures found in 10 consecutive high power fields in the most mitotically active part of the tumor. So we'll talk about the specific scoring for that in just a minute. But in general, when you take these 3 variables and score up the points for each one, if you have a score of 3 to 5, that's a grade 1 tumor. So in other words, you can have 2 2s and a 1 and get a 5. That's still a grade 1 tumor. In contrast, if you're 8 or 9, only 1 or no variables that are less than 3, you're clearly in grade 3. And then the vast majority of tumors obviously will land in the middle zone, grade 2. Now, if you want to use this table, it can be useful based on your microscope field diameter. You can then estimate the size in square millimeters of your viewer, and then use these cutoffs for the number of mitoses per 10 high power fields that would fall into either score 1, score 2, or score 3. Of course, these are fairly loosely defined. As you can see, there's some variability in field size and so forth. But knowing where your threshold should be 4 versus 5 for a score of 1 is probably critical. Or if you're even looking at a very large field, you may even be able to get 10 mitoses in to a score 1. So take some time, figure out what your field diameter is, use your micrometer or use a tool to estimate your field diameter, and then pick where you should be in terms of the scoring cutoffs for the microscope that you use most of the time. Okay, so let's go on with looking at some samples of no special type ductal carcinoma, and we'll practice doing the grading. for a few cases. So here's our infiltrative tumor right here. We've got some solid area that's probably ductal carcinoma in situ associated with it. And then we see that these infiltrative nests generally are not forming much in the way of tubules. So this is probably a score 2 or 3 on the tubule formation side of things. But when we come down and look at the nuclei, they're generally quite small, uniform. These are grade 1 nuclei. And so then what would remain is to do our mitotic count. And obviously, I'm not going to be able to do that really easily here for you. But under your own microscope with a 40x lens, you should be able to look at 10 fields and determine whether or not you have reached your threshold for a score 1 or score 2. This, in our hands, scored as a score 1. And so for mitoses, so was a 3 for architecture, a 1 for nucleus, and a 1 for mitotic score, thus a grade 1 tumor. Here's another case. Again, we can see at low magnification, this needle biopsy. We've got some solid nests, and we've got an infiltrative pattern in several different areas that looks fairly solid. So yes, small solid nests, no tubule formation. This is architecture score 3. Looking at the nuclear features, well, I think we're seeing a little bit more nuclear pleomorphism. We're seeing some enlarged nuclei. So I think this is a case that's probably going to get a nuclear score of 2 on the basis of a little bit higher degree of pleomorphism. Now, obviously, nuclear grade is the most subjective of these criteria. And so you have to develop a little bit of practice, which is why we've given you these digital slides to practice and look at. I think I did see a mitosis or 2 here in this lesion, even at this magnification. And so this was probably either a 1 or a 2 for mitotic score. So it'd be a 3, 2, 1, or 2. That would give it a score of 6 or 7, and thus landed in a Nottingham grade 2 category. Another tumor, another example. Lots of these, very straightforward to see a lot of times. You don't even have to go to high magnification sometimes. But you can see here we've got some solid areas down here. We have a little bit more diffusely infiltrative pattern up here that might look a little bit more like lobular carcinoma, because it looks like we have some sort of preserved ducts with some elastosis around them. But notice as we look at these tumor cells that they are forming small sheets and clusters. It's just that the fixation in this particular area was not as good. And here on this other fragment, we can see that we have nicely clustered cells, groups. We are getting and provoking a bit of a desmoplastic response. The old scirrhous carcinoma or scar-forming cancers tended to provoke a very nice fibrotic response with some elastosis as well. This tumor, the nuclei to me appear relatively uniform, so I'd probably score them as grade 1 nuclei. And so this may be, again, a grade 1 tumor based on that feature. The solid architecture and presumably a low mitotic score. Now, obviously, mitotic score being based on consecutive high power fields is influenced by tumor cell density. So a tumor field that is totally filled with tumor cells is probably going to have more mitoses than a field such as this, where the tumor cells are quite widely scattered. There's a lot of intervening fat and normal tissue. And believe it or not, this factor is taken into account in terms of the grading. And so we don't make allowances for that tumor density because tumor cell density may itself be unwittingly part of the contributing factor for grade on the basis of this mitotic score. Well, what do we do when we have a tumor that is present, as in this case, in what appears to be possibly a lymph node? So technically, we do not grade tumors based on their metastatic appearance. And so tumor that has metastasized to a lymph node does not retain the ability in the same sense to have the morphologic features either of ductal or lobular in general, although the immunohistochemical features will still be there, nor does it retain the architectural features in terms of gland formation and so forth that we might use for the Nottingham score. So rendering a Nottingham score on the basis of metastatic tumor is essentially inappropriate. That said, you can give an idea of whether it's well or poorly differentiated based on gland formation, based on nuclear features and mitotic rate. And so you may choose to use those terms if you desire in a isolated lymph node. In general, we get lymph node biopsies often concurrent with breast biopsies. And when we report the lymph node ductal carcinoma or whatever, we will generally just report metastatic carcinoma as present, consistent with breast primary, and leave the grading and so forth to the breast biopsy itself. Now, this may be the breast biopsy from that same case. And so you can see that there's, maybe some staining similarities. But in this case, if we look at this, I would score this probably as an architecturally grade 2 tumor. We do have some ductal luminal features, along with areas of more solid tumor. It almost has the appearance of what has been termed an invasive cribriform type carcinoma, and potentially in some hands might be graded in that manner as well. So looking at this, again, we see rather high tumor cell density and a moderate degree of nuclear pleomorphism, some intermediate, smaller, and bigger cells in this lesion. In general, invasive cribriform carcinoma tends to be a little bit lower grade tumor than higher nuclear grade, as this appears to be here. Well, another example, this is a very obviously fragmented biopsy indicating that there's probably a fair bit of necrosis. And I put this in as a nice example of a grade 3 tumor to illustrate the features that we anticipate seeing with that. First of all, we've got a lot of inflammatory cells. And interestingly, sometimes the medullary tumors or medullary-like features in tumors will be associated with a very dense inflammatory infiltrate and a high degree of nuclear pleomorphism and kind of sheet-like growth. So this could be a medullary-like tumor. but it still classifies as a grade 3 tumor on the basis of sheet-like solid growth, high degree of nuclear pleomorphism. As you can see here, we have very large nuclei, very pleomorphic, markedly hyperchromatic, some multinucleate cells, apoptotic cells, karyorectic debris, necrosis, and usually going along with this is going to be a high mitotic rate. Here we can see in this one field, here's 1, 2, probably some more over here. So, you know, if you're able to examine this under your own microscope, you would easily reach a fairly high mitotic count. So a nice example of a grade 3 tumor in comparison to some of the earlier lower grade tumors that we have included in our series. Here's another case to sort of test yourself as you examine it. I think you can see small cords and nests. Is this lobular or ductal? Well, it's not single file. They're fairly large cells. Look at these nuclei here. So an interesting variation, probably a ductal tumor, but nuclear grading could be probably a grade 3. So a 3-3, and then whatever you get for a mitotic grade is going to put this probably in a grade 2 tumor, unless you happen to be able to find 10 high power fields that will give you enough mitotic figures to make it a score 3. Certainly possible that it could be. For digital sign out, I think we're going to want to have a 4DX scan of things like this in order to be able to do good mitotic counts, or perhaps some adjunctive artificial intelligence. Another case here, we can see solid sheets, perhaps an in situ component here, kind of a solid in situ component here and here. And then here, the invasive pattern. No formation of tubules or ducts. Well, maybe a little bit here, but predominantly solid. I think I would score this as an architectural score 3. Nuclear-wise, I think it's still in the kind of grade 2 category. We do have some pleomorphism, some marked enlargement, and mitoses, of course. Then you see here with this more cellular tumor, you may get a higher mitotic count from this than you would from that previous tumor where there was more stroma. So there's a mitosis. Maybe we can find another here. Perhaps another one there. So this could be a 3-2-2, probably a grade 2 tumor based on that frequency of mitotic figures. Another example, again posted as an unknown for you to examine and look at, make your determination. Seeing the number of cases that we've got should help you. Notice here that in this case, we have associated in situ tumor with necrosis and probably some calcification here. Here you see some cholesterol clefts in an adjacent duct. And there's not much remaining ductal carcinoma in situ around here. But this is not a ultra high grade nuclear grade 3 type of DCIS. And looking at this tumor, we have a few rare ducts maybe here, over here, but generally a solid pattern, small nests and cords, grade 2 nuclei, and then you conduct your mitotic count to determine. Another in situ area. And Dr. Ramsayer has come through with some annotations. I think you can see, no annotations on this one yet. All right, so we'll keep going here. Another example, multiple foci here in this tumor, some solid areas. Here's probably some solid, some almost cribriform-like ductal carcinoma in situ. You see multiple, generally rounded spaces, fairly uniform nuclei, but higher NC ratio and some streaming and solid-like areas to give you an idea of that DCIS pattern. Maybe a more solid type DCIS over here. And then transitioning to invasive tumor, areas of hemosiderin deposition and hemorrhage as we go further afield in this case. Take a high magnification view and look at the the nuclear features here. This is sort of an intermediate grade tumor with intermediate grade nuclei. All right, well, let's move on to lobular carcinoma. As we've mentioned, this infiltrative pattern, very poorly cohesive cells. And one of the features of this cancer is that it tends to surround existing structures. So it, rather than displacing or destroying them, it sort of will produce this Indian file or somewhat target-like pattern around existing structures. We've mentioned the intracytoplasmic lumina, signet ring forms, and there is a pleomorphic variant that is a higher grade. Now, additionally, this is a tumor that can easily be missed on a needle biopsy with a small piece of it only, or a more histiocytoid-like area. You can be deceived into thinking it's inflammation or reaction. So this is a tumor that needs a high degree of suspicion, both for the radiologist and for the pathologist. Now, this is not a subtle case. Obviously, each of these fragments has some abnormality here. And notice this, the way it sort of takes over the fat here. So we'll just go down here a little more high magnification view on this. And you can see this sort of streaming, single file, very discohesive, almost single cell infiltration pattern of this tumor. No large nests, no ductal tubular differentiation, just a little bit of pleomorphism to this particular variant. Some variation in size and shape of these nuclei could put it into the pleomorphic category. And it sort of produces this almost fat necrosis-like appearance. So you can imagine if these cells, you thought these were histiocytes because of the fat necrosis, foamy cell changes, you could easily discount this as a carcinoma unless you did the cytokeratin stain or a CD168 stain and discovered that these were negative. So look a little bit at another field here. Here perhaps. And we'll try to demonstrate some of the more targetoid-like areas. So here is a normal tubular duct here, another one here, and a few cells sort of going around here in the stroma around this partly destroyed duct. Well, that's not the best demonstration of targets that I can imagine. I'm sure we'll find others here. Let's go on to the next slide and see if we've got some there. Again, we see this infiltrative pattern. Here's some. Well, it looks like here we've got probably a little bit of lobular carcinoma in situ involving a terminal duct, because these are the same cells that we're seeing out here in this rather subtle infiltrative pattern here. So notice how small these cells are, and oftentimes the nuclei will sort of be boxcar-like next to each other. with the nuclei sort of having a long axis perpendicular to the direction of the infiltrated strand. So that's a fairly frequent appearance, and some degree of nuclear molding is also encountered. Now, this I show you to illustrate the fact that in lymph nodes, the architecture may or may not be preserved. But in this case, we see what looks almost more like a little bit of a ductal type carcinoma, because here these cells are forming, small nests and rounded structures. And they look a little bit more like ductal carcinoma, but this is in fact metastatic lobular carcinoma involving this lymph node. Now, there are obviously features here that would be compatible with lobular, like this little strand of cells, 4 in a row, linear stranding, and so forth. But there are times when you can be easily deceived when you get a more solid, coherent cluster like these, and think, okay, well, this is metastatic ductal carcinoma. So again, the caveat, don't try to categorize it strictly on the basis of how it looks in the lymph node. All right, well, here's another example, and I think here we'll be able to see the targeting feature. If we just go right up here to this area here, we see some edematous, well, right over here perhaps is even better. A little residual lobule here. Well, it's not doing what I want it to do. Here's the pattern. Okay. So here's our retained lobule. And notice how this tumor is encircling and to a certain degree invading this lobule. Well, this is the targetoid pattern of lobular carcinoma, is encircling an existing structure, usually a duct, but in this case a lobule, and giving this sort of onion skin or rounded appearance around that lesion. So here's a duct here, and here are the targetoid-like strands of this invasive lobular carcinoma sort of streaming around the campfire of the lobule here. Now notice here that we can occasionally get little seeming clusters. Sometimes this is lymphatic space invasion, sometimes it's just retraction from a larger coherent, cohesive group that got pushed together. Back to our original slide, we looked at LCIS on. Again, I think we'll be able to see here a little bit of the targetoid type of growth. If we look at these ducts out here, now you might think, oh, these are just inflammatory cells. Yes, some of these are inflammatory cells, but you also have, in this mix, you have these atypical tumor cells that are involved in this infiltrated process around this duct. And notice how these cells, I mean, they can just look like very isolated histiocytes. You can imagine how these could be mistaken in the right context for histiocytes. Another example. Here, a more densely cellular area with a little bit of cohesive growth. And sort of nested pattern. So in circumstances like this, doing immunohistochemical stains not at all inappropriate to either see if you've got a sort of mixed morphology or if you can characterize it as lobular. Sometimes we just end up calling it, invasive mammary carcinoma or carcinoma with ductal and lobular features because there are certain overlap groups where you can see both kinds of differentiation present. Here's a little bit of targetoid growth around a vessel, but not with a little bit more cohesive sense to the, or at least clustering of the cells together. Again, tumor in a lymph node. And this is a case where you have to recognize that lobular carcinoma metastases to lymph node can be extremely subtle. And that's why I put this slide in, is because I want you to come around and go around the subcapsular sinus and all of these intraluminal sinuses to see when you can identify the metastasis. Sometimes you need to go at 10x, 20x or higher to be able to pick up a subtle metastasis from an invasive lobular carcinoma. Because as you see, many of these histiocyte cells look very similar. Now we do have here a bit of dermatopathic lymphadenitis with pigment and so forth in the lymph node. And of course, if you have doubts, you're uncertain, upstaging with lymph node mets is certainly an important feature to evaluate and to know about. And so immunohistochemistry is not inappropriate as an adjunct to evaluation of lymph nodes. So I'm not going to show you where the metastasis is here, but leave this for you as a challenge to come back and find the metastatic site on your own time. I think I'll skip this slide. It's a little bit washed out, and we've covered a lot on lobular carcinoma. More examples for you to study on your own time as we go through this. I think I've said about all that needs to be said, but I wanted to make sure that you had plenty of examples, because I do think that you need to see 10 or 15 examples of a lesion before the pattern can be firmly fixed into your mind. This is this sort of diffuse, subtle, paucicellular infiltrative pattern that you can imagine getting just a piece like this on a needle biopsy if it was going through the other direction, and having a very hard time saying, are those histiocytes? Is that tumor? Sort of thing. So just be aware that lobular carcinoma is a challenge. Okay, tubular carcinoma, another special type. This is a low-grade tumor that has very small ductal structures, has low-grade nuclei, and a single epithelial layer, no myoepithelial cells involved. It tends to have a sclerotic stroma and sometimes stellate pattern that may resemble a radial scar, but it does. You may have elastosis here, as in radial scar, but the absence, elastosis is much more frequently seen in a radial scar, and no myoepithelial layer, obviously, as well. And sometimes finding these sort of apical snouts or little projections on the apical cytoplasm is helpful in this diagnosis. So here's a case that is touted as being tubular carcinoma. You'll see the majority of these groups are small tubules, small ductal spaces. And as we look at these on higher magnification, very small cells, generally small nuclei. And let's see if we can find any nice snouts in this case to illustrate that feature for you. Well, I'm not seeing that very well here, but you can see how these are sort of a single layer. We'll have other examples that will show you maybe better the apical snouting. Obviously, low cellularity, your mitotic count's going to be very low in this tumor. If you were to grade it as a Nottingham grade 1, you wouldn't be in bad company, but recognizing the variant can be a nice talent to have in this circumstance. We have another example here. And of course, looking at this at low magnification, you go, where's the tumor? Oh, okay, right over here. You see most of this is benign breast tissue, and then we've got this one area right here. And you can see how this might look a little bit like a radial scar. And it's a little bit sclerotic and so forth. And you've got small ducts entrapped here. But notice we're not seeing elastosis. We're just seeing a very uniform picture of small ducts, small tubular structures. And this is a case which I believe has nice apical snouts. So here are some wonderful examples of apical snouts. These little tufted projections of cytoplasm into the lumen. These are apical snouts. And there's some nice examples here. Several of these ducts, tubules with nice examples of that. Now notice you can occasionally get sort of almost lobular-like features with a little Indian file-like formation. That shouldn't disqualify this from being a tubular carcinoma. So here's another duct. Even at low magnification, you can see the snouts on this one here. Just nice projections into the lumen. This was the first case we talked about. I think we'll just skip over that. And now let's talk about cribriform carcinoma. This is a low-grade carcinoma that's similar to tubular carcinoma, but the islands of tumor have a cribriform pattern, just like a cribriform ductal carcinoma in situ, but there are no myoepithelial cells. So again, in this variant, we can have apical snouts and sort of secretions like those that we just saw in tubular carcinoma, but we don't see them with any great frequency. And this is a relatively uncommon carcinoma. I could not find a good example to share with you. So I'm going to skip on to mucinous carcinoma. This is previously known as colloid carcinoma and is characterized by these abundant pools of mucin with just free-floating islands of epithelial tumor. Sort of like mucinous carcinomas of the GI tract or elsewhere. The mucin does the dissection and forms the mass, and there therefore tends to be a higher tumor mass than cytologic tumor burden. And this is usually the luminal A subtype, which is ER/PR positive and HER2 negative, and therefore it's usually a good prognosis tumor. It's very easy to recognize, and I've got a couple of nice examples here for you. It tends to be quite blue, as you see, because the mucin stains blue. And then you see these little islands of cells within the pools of mucin. And it's the mucin that's doing the dissection, obviously. So coming into higher magnification, we can see that these tumor cell nests, generally rounded because they're in a fluid environment, a mild degree of nuclear pleomorphism, but not high grade. And generally the cells are coherent, lining up, sort of thing. They don't tend to have a lot of intracytoplasmic mucin and so forth. Grading for this tumor, generally not included in the Nottingham scoring system, but you certainly are welcome to provide a nuclear grade, which should be low, 1 or 2. And by virtue of the fact that the cellularity is going to be extraordinarily low, it's undoubtedly going to be low mitotic score. And so you're going to be left with a low-grade tumor. Another example here, and this nicely illustrates the fact that there are certain in situ variants of ductal carcinoma in situ that tend to be more associated with this than others. So here's sort of a solid variant that can be associated with this tumor. And you see it's producing mucin and so forth. And then as it escapes into the stroma, you see that sort of happening. It's sort of extruding the mucin here. And you can see it sort of spreading and the tumor cells free floating into the lumen. So I'm not sure biologically if this holds a lot of weight, but it certainly seems logical to believe that one of the reasons this tumor has a good prognosis and tends to generally be low stage on first appearance is that in this case, it is the mucin that is doing the dissection and providing the avenue for spread of the tumor rather than the cells themselves. And so to the degree that that mass appears early and before the cells themselves have a high capability for stromal invasion, that is going to portend well for the patient. Another example, sometimes you can see this associated with large ductal mucinous spaces, as you see here, and a fair degree of sclerosis, kind of almost more like the type of fibrosis that you see with low-grade appendiceal mucinous tumors. Mucin can be a fibrosis-inducing agent, so if it's been around for a while, you may get mucin very juxtaposed this dense collagenized fibrous matrix that we would see in a lamin or other tumors of this sort in the GI tract. Now, occasionally you'll get to higher cellularity, and that certainly may not have quite the same prognosis, but here you're still seeing abundant mucin in this tumor with the tumor cells floating in the mucin pools. Rather than being sort of tissue invasive and then producing mucin. So that is the feature we would tend to use more, is tumor cells sort of floating in a mucinous background as opposed to invading primarily. Mucinous cystadenocarcinoma is quite uncommon. And I don't have a good example to share with you, but suffice it to say that it's very similar to intraductal papillary mucinous neoplasm of the pancreas, or ovarian-type mucinous carcinoma of the pancreas, or ovarian-type mucinous carcinomas, which tend to have a mucinous cystic lesion with then the development of an invasive carcinoma that generally has tissue invasive capabilities. Now, invasive micropapillary carcinoma is a distinctive subtype. This is a tumor that has sort of an inverted pattern, which shows a clear pericellular space that then has the little cluster or morule of tumor cells in the midst of that space. Now, this can be a component in other forms of ductal carcinomas, and these cellular clusters are free of any fibrovascular core. Epithelial membrane antigen will stain the peripheral stroma-facing surfaces of the cells, which is a useful adjunct at times. So here's an example, a needle core biopsy, and you see this invasive pattern. And we'll just sort of focus down here at this end of the sample to illustrate what we're talking about here. So in this micropapillary invasive carcinoma, virtually every cell group is surrounded by this clear pericellular space. There's no central core, fibrovascular core, and the tumor cells tend to be a little bit on the higher grade side of things. There may be other invasive components associated with that. And so this is where, if you have a question, then doing something like the EMA stain to see if you're getting that characteristic pattern. But this sort of a retraction artifact is really a manifestation of the inverted or reversed polarity of these cells that have lost their cohesiveness to the surrounding structure. Let's see if we have another example here, I believe. Also showing this pattern here with a more sclerotic background. And I think, again, at low magnification, you can see that these areas are highlighted by this clearing around the cell groups. And that should be a signal to you at low magnification to look and consider this type of a tumor, where you see this very pericellular clear zone in every cell group or in every cell group in a region like this. That should alert you to the possibility of micropapillary type carcinoma. A nice example, I think, to show you that pericellular clearing and the inverted staining, inverted pattern of polarity. Here's another example. Again, you can see at low magnification, this sort of small clustered cell groups and lots of perigroup clearing. Nice micropapillary features. Now, here there may be other areas. There's more of a DCIS type pattern here with some lymphoid stroma, but this is, again, pretty classic appearance of micropapillary carcinoma. And notice these very delicate, thin tissue strands between these micropapillae. This is, again, indicative of this change. Boy, that's so good, I should take a picture of that. All right, we're going to go on. Hopefully I didn't mess this up too badly. Okay, carcinoma with Apocrine differentiation. Well, we know what Apocrine differentiation, Apocrine metaplasia is. This is the neoplastic variation on that theme. Generally very large cells with abundant eosinophilic cytoplasm and quite prominent central nucleoli. The cells generally will have sharp borders, and these tend to be higher grade tumors with a little higher grade mitotic activity. So most of these tumors tend to be grade 2 or 3. And significantly, these tumors can stain positively with androgen receptor as opposed to estrogen receptor. So let's take a look at this tumor here. We see some solid tumor cells, tumor areas. We'll go down to a little higher magnification. And I think we'll be able to identify that these cells have quite abundant eosinophilic cytoplasm. These tend to be pink tumors. And notice here that it's, there's so much cytoplasm, it's almost hard to find the nuclei in some areas. Now, this is an example maybe of a lower grade tumor, but we still have some degree of nuclear pleomorphism, wonderful macronucleoli, and we're forming a solid pattern. So this is sort of maybe an in situ kind of area here, where we've begun to fill the lumen. And we'll see, I think, in other areas of this tumor, evidence of invasive tumor down here. So here we're seeing a more likely to be invasive pattern of this tumor with smaller nests, occasional single cells, and so forth, involved in this background fibrotic tissue. This is a tumor which we have occasionally seen with just pure lymphatic invasion, lymphatic space invasion. So occasional tumors may be spread widely within the breast and a little bit subtle in their presentation. My colleague, Dr. F, got a rude awakening in some of his early cases with one of these lesions that was quite subtle in its presentation. So both an in situ as well as an invasive version of this exist and can be identified. A lot of this, I believe, is still in situ, but we may have areas like this where either we're involving sclerosing adenosis or we're beginning to spread in the stroma. Okay, metaplastic carcinomas are a heterogeneous group of tumors. Metaplastic because they're changing. So there's some sort of differentiation towards squamous and various mesenchymal elements, including chondroid, osseous, and so forth. This is a tumor where if you see an in situ component, you're fine. But if you don't see an in situ component, you may need to provide some sort of evidence of epithelial differentiation, either a cytokeratin or P63 features to demonstrate that the tumor has an epithelial component. Because these are so bizarre and funny looking, people like to share these cases. So you'll actually probably get an impression that these are common. Here we can see an area of DCIS type of tumor, maybe a little bit more here. And as we look at this tumor, we see an invasive component. And sure enough, it looks like this is forming kind of a keratinizing type of carcinoma. Squamous differentiation is evident here. So that kind of defines the case, defines the entity, at least in the bare minimum, seeing that squamous differentiation along with an area in situ carcinoma. See if we have some examples with other elements. Yes, I think so. Here we see areas of nice carcinoma here with a little bit of suggestion of squamous differentiation here. Some calcification. Now, one question that might be asked is, why do we not call this, sarcomatoid carcinoma of the breast, as we do in so many other areas? And the answer is, I don't know, other than the fact that this term is in the literature. So here's some area here that's sort of beginning to look a little bit more myxoid and so forth. Further in this case, we've seen the squamous differentiation. Again, I apologize for the slow server here. Here's a little bit of in situ tumor. And here's a very kind of hyalinized stroma. It's not truly osteoid, but looks rather distinctive. So here we can begin to see maybe a little bit of that, more of that hyalinized stroma. So squamous differentiation, some in situ tumor, and certainly dense stromal hyalinization to go along with that. Another example. Here's a case where we can see rather nice kind of chondroid type of differentiation here, very blue myxoid type stroma. Some of these previously were called mixed tumors and so forth because of this sort of metaplastic chondroid type stroma. More of that here. This piece is going to come into focus here. And I think right down here. Dum da dum dum dum. Well, yeah, so it's just more of this sort of chondroid type feature, but you also see a little of the squamous. And here you see single cells within the chondroid type tissue, type stroma that would give you that nice sense of sort of chondroid type of differentiation. So that's another example. This case here, I think, typical epithelial component over here. Some sort of clear cell areas. High-grade tumor, and then we see this area over here with a clear, very mesenchymal-ish look, pleomorphic cells within this fibrinoid, slightly hyalinized, almost osteoid-like stroma. So if it looks kind of like a carcinosarcoma, you're probably dealing with what's better or currently termed metaplastic carcinoma in the WHO. So here's another instance, a little bit different story. This is a tumor that looks a little bit like sort of a fibromatosis. You see this sort of stellate fibrosis that's going on here. And fairly cellular. But notice that it has a few epithelial cell groups in it. There's another one over here, another one over here. And so typically, you might think of a desmoid fibromatosis and consider whether or not it has a beta-catenin situation as well, and mutation. But there also is a fibromatosis-like variant of metaplastic carcinoma that can be rather deceptive as well. So that's kind of an advanced topic, but just to give you an idea of some of the other things to be thinking about in these lesions. And considering, in addition to doing the beta-catenin stain, you may want to do some keratin stains to make sure that you're not looking at some metaplastic carcinoma with a low-grade sarcomatoid appearance. Another example, here you can see deep to the skin. We don't see a lot of epithelial component. We do see some DCIS here. And here you can again see this very spindly shaped lesion, very busy, sort of desmoid-like type of lesion with a lot of atypia here. Not high-grade atypia, but certainly some atypia in these stromal cells and accompanying inflammatory changes as well. So another unusual variant of carcinoma with the metaplastic features of a more low-grade type lesion that mimic fibromatosis or a low-grade spindle cell sarcoma. The clue here being the identification of this very low-grade DCIS and occasional identification of, here you see features of metaplastic squamous epithelium sort of streaming off into that stroma. So I know that at first you didn't believe me that this was a carcinoma, but here you can see nice evidence of these little squamous pearls associated, or squamous morules in this lesion, along with the focal areas of DCIS. Another example, I'm going to leave you to study this one on your own, and we will try to, as I said, there's lots of examples on our teaching files. Here's one that's closer to the skin, extending up into the skin. This could be mistaken for melanoma or for other types of lesions, you know, in this situation. With this very metaplastic, mucinous, fibrosing pattern, think sarcomatoid carcinoma. Well, finally, we will mention that there are salivary-type tumors that can occur in the breast. It's been spoken of at times as the sort of large salivary gland elsewhere. But these are the main types you're going to see. We're not going to spend a lot of time on these here today. But here's a nice example of an adenoid cystic tumor. These essentially look like their counterparts in the salivary glands. And so you can refer to our teaching videos on salivary gland tumors, which are in the works. It will come out later. Nice example with these nests and tubule, hyalinized tubules and so forth. And these will generally have similar immunohistochemical staining patterns to those that we see in the salivary glands. Another example, solid nests, tubules, occasional hyalinized structures. And so if it doesn't seem to fit well into a ductal carcinoma, don't rule out the possibility of one of these salivary-type neoplasms. Secretory carcinoma it's another variant of salivary-type carcinomas. And of course, this has a very characteristic molecular phenotype as well, just as it does in the salivary ducts. So here you see the secretion, you see the very large eosinophilic cells, a lot of pink cytoplasm, and inclusion-like features that are associated with this tumor. Another example from a biopsy, certainly a very challenging setting, but you can see again nested cells, secretion, a little bit of foaminess to the cells, abundant cytoplasm, generally fairly round nuclei, prominent nucleoli. and the characteristic immunophenotype. So we've hit the end. I'm hoping that having worked through this, you'll be ready to handle about 90% of the breast tumors likely to come your way. If that's not the case, well, please go back and look at the slides again and shoot me a line if there are ways that we can make this better or improve it with side-by-side comparisons. We thank you for your time spent with us on this and wish you all good speed in your efforts to grow your diagnostic acumen. So until next time, thanks so much for joining me.